Hello everyone, let's discuss varicocele. Varicocele is nothing but abnormal and irregular dilatation of scrotal venous plexus which is draining the testis. These are abnormal, irregular dilatation of scrotal venous plexus. These drain the testis. So we need to understand a little anatomy here. So this is left testis and this is right testis, and we have inferior vena cava here, and this is right renal vein and this is left renal vein. Left testis is drained by left testicular vein into left renal vein. On the right side, right testicular vein directly drains into inferior vena cava. So this is left testicular vein, this is right testicular vein. On the left side it is draining into left renal vein, and on the right side it is draining into inferior vena cava directly. So if this is testis, all the veins draining the testis will form a plexus called pampiniform plexus. They traverse through the inguinal canal, and if this is inguinal canal, they traverse through the inguinal canal, and near the deep ring they will join to form testicular vein, and this testicular vein will be draining into left renal vein on the left side, and on the right side they are draining into inferior vena cava directly. If these pampiniform plexus are dilated, this condition is called varicocele. So when these pampiniform plexus are dilated and tortuous, this is called varicocele. Let's know about the incidence of varicocele. Varicocele is seen in 10 to 20% of the male, usually seen during late childhood and adolescence. So most common age group are late childhood and adolescence. It may also be seen in older males, and in such cases you should suspect renal vein thrombosis or renal tumor encroaching into renal vein. So in such cases there will be varicocele, but such varicoceles don't regress on supine position. Actually, on supine positions, those irregular dilated tortuosities will be regressed because of increased drainage. But in cases of renal vein thrombosis and renal vein occluding the and in renal tumor occluding the renal vein, those varicosities won't regress at all. This is most commonly seen on left side. There are few reasons why varicocele is most common on left side, because as you can see in this image, it is most common on left side because of first thing, angulation. Left testicular vein is joining into left renal vein at a more of a 90-degree angle. So this is one of the reasons. And number two, left renal vein is a high pressure system and IVC is a low pressure system. So as we can see, it is easy to deliver blood into a low pressure system rather than a high pressure system. So it is varicoceles are most common on left side. Left renal vein is a high pressure system. Than IVC. So there will be defective drainage from left testicular vein to left renal vein, owing to more varicoceles on left side. Number 3, on the left side, the sigmoid colon will compress left testicular vein, leading to decreased drainage from pampiniform plexus, leading to development of varicosities in pampiniform plexus. Because of these reasons, varicoceles are more common on left side. And isolated right-sided varicoceles are very rare, and in such cases you should rule out retroperitoneal tumors. Isolated right-sided varicoceles are rare and rule out retroperitoneal tumors in such cases. Now let's see pathophysiology of development of varicoceles. Why do these varicoceles develop in the first place? Because of failure of anti-reflex walls. Let's see this image once again. There are anti-reflex walls present at the junction of renal vein and testicular vein. In this image, you can see those anti-reflex walls here. At the junction of left testicular vein and left renal vein, and at the junction of IVC and right testicular vein. So they prevent backflow of blood into the gonadal veins. So if such anti-reflux walls are absent or defective, so there will be more blood coming into gonadal veins, so leading to development of varicosities in pampiniform plexus. Number 2, nutcracker effect. If this is aorta and this is superior mesenteric artery arising from aorta, this is left renal vein. Left renal vein might be compressed between superior mesenteric vein and aorta. This is called nutcracker effect. Since this vein is compressed, it can't drain blood from testicular vein into the renal vein because of occlusion. So varicosities will develop in such cases. Number 3, some of the rare causes of development of varicoceles are thrombosis of pampiniform plexus and renal AV malformations. So let's discuss clinical features of varicoceles. Most of these varicoceles don't cause any symptoms to the patient. This is mostly asymptomatic. And it is symptomatic mostly in late childhood and adolescence, where it is more common. It is more symptomatic in adolescence and late childhood. So what symptoms do varicoceles will present with? These patients will have dragging sensation in their groin. This dragging sensation is more worse at the end of the day. So this patient came to you with dragging sensation, and now you are examining this patient. So let's see the examination findings. On inspection and on palpation, what do you see? Typically we examine these patients in standing position because decreased drainage because of gravity. These varicoceles will be more prominent in standing position. So you might see varicoceles on the affected side of scrotum. You will see varicoceles on scrotum on affected side. Number 1. And number 2, the affected testis is a little lower than the normal one. So if this is left testis, if this is right testis, when you compare the level, the affected testis will be a little lower. Coming to palpation, which is also done in standing position, you can feel these varicoceles as a bag of worms. And you will have a positive cough impulse. And when you ask this patient to lie supine, these varicoceles will disappear, because in supine position there will be increased venous drainage because of gravity. So more of the blood will be draining from testicular vein into the renal vein or IVC, so those varicoceles will disappear. And the only exception is in cases of renal tumor, where this blood won't drain into the renal vein. Testicular vein blood will not be draining into renal vein, and those varicoceles will not disappear even in supine position. So, and in supine position, varicoceles will regress, and you know the exception. So how do you diagnose such cases? Diagnosis by clinical. You can see varicoceles, you can palpate them as a bag of worms, and for a smaller varicoceles where you can't see them clinically or you can't express them by Valsalva, you will diagnose them by Doppler. So there is this classification for varicocele where you have subclinical and few grades 1, 2 and 3. In subclinical, these will be diagnosed, those varicoceles will be seen only on Doppler. You can't see them clinically. In grade 1, you will be seeing them only on Valsalva. So when the patient does Valsalva, you can feel them, otherwise you can't. And in grade 2, you can palpate those varicoceles at rest, but you can't see them. And in grade 3, you can palpate and inspect them and see them dressed. So this is classification for varicocele. There is this thing called infertility, which is more commonly seen in patients of varicocele. So let's know about the association between infertility and varicocele. %25 of the men having infertility are having varicoceles. So 25% of the men with infertility are having varicocele. Why are they having infertility? The exact reason is not known yet, but the most accepted theory is this. Because of you'll have more amount of blood in dilated tortuous veins. So increased blood in these varicosities lead to more blood around the testes. They will increase the temperature around the testes. This leads to derangement in spermatogenesis. As we all know, the only reason testis hangs outside our body is because of spermatogenesis. Since because of these varicoceles, this temperature is increased, so the spermatogenesis will be deranged. This leads to abnormal sperm count. There will be low sperm count and abnormal sperm morphology, abnormal sperm viability and motility. So all this will lead to, and we can see them in semen analysis. And in long-standing cases, there will be testicular atrophy. So how do we manage these such cases? Management of sperm varicocele will be effective in men having, actually we do surgeries only in men. We avoid surgery in adult childhood. So we will do surgeries in men having clinical varicocele where it is disturbing the patient and having low sperm count and unexplained infertility. These are the indications where you operate varicocele in a patient, and we only do them in men with clinical varicocele, low sperm count and unexplained infertility, and we avoid surgeries in adolescents. It may lead to over-treating them. Because most of these kids will not be having any problem with fertility in the future, so why operating them and have them difficulty? So we usually avoid surgeries in adolescent males. So in case of significant discomfort, in case of significant discomfort, we will do percutaneous embolization of testicular veins. So this is the first line of treatment where we do in varicoceles. So we will embolize the testicular veins, and there is high chance of recurrence after the surgery. So if there is a recurrence, percutaneous embolization is not possible, in such cases we will do surgical ligation of testicular veins. Even with, so we have discussed two modalities here. We'll do percutaneous embolization as a first line treatment, and if that is not possible, or if there is a recurrence after percutaneous embolization, we will do surgical ligation of testicular veins. And there is high amount of recurrence with both of these two procedures, and there is this thing called microvascular varicocelectomy. This is the most effective treatment for varicocele available as of now. This is the most effective treatment, and this is having low amount of recurrence and very low amount of complications. See, if this is penis, this is scrotum, I have testis here. So we will give a subinguinal small incision, a 2 to 2.5 centimeter incision. We will give it subinguinally, and we'll dissect and identify the cord, and we'll ligate the internal spermatic veins. So it is a simple procedure, and this is the most effective procedure available for varicocele. And you might be wondering what will drain the blood of testis if testicular veins are ligated. So the only mode of drainage of testis after ligation of testicular veins is by veins around the vas deferens, which are present in vasal sheath. This concludes the lecture of varicocele. Thank you.